Good afternoon, everyone, and I would like to welcome you to this week's session, that is session 16 of 2019 of our HIV ECHO program. And today in the hub, we've got a special guest who will be the expert for the day and presenting the didactic. And I think you are all welcome to contribute because we'll be discussing something that is of contentious nature, especially with regards to maternal and child HIV issues. Now, before we do that, I think we'll straight go away to have a recap of last week's program, which was TB prophylaxis treatment, and this will be given by Dr. Foloshi Sombo.
Good afternoon, everyone. Thank you very much, Dr. Mpeta. So last week we discussed IPT, now known as IPT, because aside isoniazid, you can actually use rifampicin and have a shorter regimen. We learned that there is a new change to our guidelines. In the previous guidelines, we were saying that only give IPT to people with HIV commencing ART. Now we have robust data that suggests that even people with a CD4, even more than 700 on ART do benefit from prophylaxis treatment of the TB. Mortality is reduced to up to 37%. We also learned that despite use of INH, those who proceed and develop TB actually have a very, very low risk of resistance.
So thank you very much, Dr. Foloshi, for that recap. We'll now go straight into introductions, and I've seen a number of hospitals, individuals have actually joined from our network, and probably we might not go through the introduction one by one, but by show of hands, you can just indicate so that we know that you are able to get us from here. So Chilenje, if you could just raise your hand if you're able to get us loud and clearly. Thank you very much. We've got the Wuyu Clinic. Thank you very much, the Wuyu from Livingstone. We've got the Tambia Rural Health Center. Tambia, thank you very much. Quite an overwhelming attendance there. Minga Mission. Minga Mission. Minga Mission, are you able to get us? Okay. We'll get back to Minga now. Namwaseche. Namiseche. Can you wave if you're able to get us? Thank you very much. Njase Aban. Njase. All right, we can get a signal from Njase. Sons of Thunder. We expect a lot of attendance from there. Sons of Thunder. Can anybody see? Are you able to hear us? St. Francis. Thank you very much. Yeta District Health Hospital. Yeta. Thank you very much, Yeta. We can see there's one person there. Levi Wanawasa, are they in? They joined in for the first time last week. Levi, thank you very much. You can see, you can hear us with the Chinese writings there. I hope that means Levi. Livingstone Central. Livingstone Central. Okay, we are yet to get a feedback. Chipata Central and Chipata District Health Hospital. Okay, so thank you very much. To facilitate today's program, my name is Dr. Francis Mpeta, and I'm an infectious disease doctor. So before I introduce the didactic presenter, I would like to remind each one of us of the etiquettes of today's session. Let's ensure that we put all phones on off. And please, if you are not on the floor to speak, kindly ensure that your microphone is on mute. And let's minimize movements as this actually distract other participants. So today I think we've got a special guest all the way from the United States, and this is Professor Doug Watson, who is going to talk about the hot topics in maternal-child HIV. Prof, welcome to Zambia.
Thank you. It's good to be back.
Thank you. Welcome.
So I was asked to touch on several different topics that I think sometimes have people wondering and what's going on. I'll tell you right now, there aren't always really clear answers, but we'll try to kind of see what we know and what we don't know. So to start off, well, you can see the learning objectives, but we'll get right to the learning. Poll question. So the first poll question is, by what age does HIV rapid test become negative in most uninfected HIV-exposed infant? By what age does the HIV rapid test become negative in most uninfected HIV-exposed infant? So we've got a few seconds there. So the poll should be on your screen. Let's keep on voting. We've got only 25% who have voted.
All over the place.
So thank you very much for those answers. We will straight go to the next poll question. Okay, so an infant 18 months of age born to a mother who was HIV seropositive in pregnancy, but with poor adherence to TLE, that is tenofovir, lamivudine, and efavirenz, as a negative rapid test for HIV today. Under what circumstances might this child be HIV infected? A, infant had negative PCR at birth and positive PCR at 6 weeks of age, and was started on ABC 3TC lopinavir at 8 weeks of age. B, infant was infected 2 weeks ago from breast milk. C, infant presented to the hospital at 18 months of age with poor growth and delay in development and severe pneumonia. D, somebody mixed up the rapid test samples. So here is the poll. We can vote in the second poll.
Okay.
We are ready to vote. So the question is, an infant of 18 months of age born to a mother who is HIV seropositive in pregnancy, but with poor adherence to TLE, has a negative rapid test for HIV today. That is the infant. Under what circumstances might this child be HIV infected? So a child who is 18 months comes today and a rapid test is negative, but the mother was positive, is positive, and poorly adherent to TLE. Now, under what circumstances might this child be infected? A, is it B, is it C, or D? And I think we have a number of people
there we go.
voting. Almost less than half. Are we still confused?
How's it looking, Dr.
Sorry?
How's it looking?
Okay, we've got at least slightly half. So we'll get back to this pause and let's try to see how we can get into the discussion. Yes.
Okay. Okay, so a topic which we hear a lot about is the issue of Dolutegravir at conception. And this is an important point, as I'm going to mention now, the issue of whether Dolutegravir causes neural tube defects. So first, let's look at when do neural tube defects occur. And the bottom line here is that neural tube is closed by 28 days, usually a little bit earlier after conception. So this means that anything that is causing the failure of the neural tube to close has to act during that time. So this is basically, about when a woman is about 2 weeks late on her menses. Okay, I think probably the majority of pregnant women, probably the vast majority of pregnant women in Zambia are not diagnosed by this time. So it's not first trimester exposure we're looking at, it's exposure at the time of conception, if that's the question. So the question is it safe to start Dolutegravir in pregnant women? So for the woman's already pregnant, she's really past the period of risk. And this actually has been looked at pretty carefully, and we know that if you start Dolutegravir during pregnancy, there's no sign of any increased risk for neural tube defect. The real issue for that woman is when she's no longer pregnant, and she gets pregnant again 2 or 3 years later, and she's still on Dolutegravir. There is the question, which remains a question, as I'll show you, as to whether or not Dolutegravir is a problem if it's present at the time of conception, and while the neural tube is forming on the order of about 2 to 4 weeks after conception. So this all came from the Tsapamo study in Botswana. This was a prospective observational study of birth defects among pregnant women in Botswana. They were particularly interested in looking at whether efavirenz was associated with neural tube defects. The country at the time was using efavirenz as the mainstay of their therapy, and during the study, they switched over to Dolutegravir as the mainstay of their antiretroviral therapy for pregnant and non-pregnant women. And this is what they found, which was rather alarming. If we go, we look at there's no pointer, I guess, is there? Oh, I can just use this? Okay, yeah, okay, here.
Oh, no, but just want to be pointing that side.
Yeah. Okay, that's fine. So if we start all the way over at the right, that's the incidence of neural tube defects in non-pregnant women, 0.09%. Generally, we would expect about 0.1% in an African population. There was no cases in women who started during pregnancy. They looked at efavirenz at the time of a conception. Again, no hint that it was anything above the background. Then over on the left, great. Over on here. Oh, okay. Where's my mouse? The mouse. There's the mouse. Okay. Over on the left here, we have the incidence of neural tube defects in women who are on dolutegravir at the time of conception, with a very wide error bar, as you can see. This is 4 cases out of 426 women, but that's 0.94%, about 10 times what one would expect in the normal population. So needless to say, this was rather alarming, but the numbers are very small, and it certainly was not expected. So what else do we know? Is there are there any other data that speak to this? There's what's called the antiretroviral pregnancy register, which has been going on for a number of years. And this is a registry where physicians will enter into the registry HIV-infected pregnant women at the time they're diagnosed with pregnancy, before they know what the outcome of the pregnancy is, whether any birth defects. If you just look at people who report birth defects, there's a bias towards reporting the birth defect. Here they're starting prospectively. And the upshot of it is, here in the left column, those that were on various ARV preconception, looking at dolutegravir and the other integrase inhibitors, elvategravir and raltegravir. If we look at total birth defects, there's no increase over the numbers seen in women exposed to any antiretroviral therapy. And in general, we expect a background birth defect rate of about 2% when just looking at general population. Now, looking at first trimester exposure, most of which is exposure at the time of conception, we have, again, basically no clear sign of increase in birth defects. And most notably, there were no cases of neural tube defects in women who were taking integrase inhibitors. The Tsepamo study has been extended, and the most recently reported data is shown here in addition to the other data. And the upshot of it here is with an additional 150 or 60 cases, now up to a total of 596. They haven't seen any more. The numerator is still 4, so now it's down to 0.67%. If we add all this, yeah. Now, an important question here is simply how precise are these measurements? How many cases do you need to observe? Next slide, please. Yeah. How many cases do you need to observe? There we go. Good. How many cases do you need to observe to be able to tell a difference? And what this shows, actually, this slide was developed to look at the question of efavirenz, birth defects due to efavirenz, but it's the same principle. And the upshot is that to see a 3-fold increase in the number of birth defects that occur at a 0.1% rate, which is about what we think the rate of neural tube defects in Africa is, you need about 2,000 observations, okay? To see an increase of 2-fold, you actually need about twice that many. So we'll need to get a lot more observations in order to really be able to see if this is really the problem or not. The study in Botswana is continuing. HIV is very common in Botswana. They've expanded the number of sites that are getting data from. The antiretroviral pregnancy register continues to collect data. So over time, we will get more and more data. So if you go to the next slide, great. So overall, what we can say about dolutegravir at conception, no overall increase in birth defects, no overall increase in adverse outcomes, which if you look at prematurity and everything, I didn't show this here, but this was published shortly after the original report. So far, it's still just the 4 cases of neural tube defects, all in the same study. Looking at all the data from different studies, the denominator is now 717, so we're down to about 0.56%. The expected, like I say, don't have really good data, and frankly, the best data is probably the data that's in the women in Botswana who are not exposed. It's probably about 0.1%. That's what we've seen in the United States also before we had folate put in foodstuffs so that basically every woman is folate supplemented, whether she knows it or not. Of course, dolutegravir is a great drug. It's a fantastic drug. There's a reason why we've been recommending it. And if we don't use dolutegravir, we have to use something else. And so what are the alternatives? There's no suggestion of birth defects with efavirenz, despite the fear because of monkey data where severe birth defects were very common. There is clearly an increase in preterm delivery with lopinavir. And especially in a setting where supportive care for a premature infant may be difficult at best, that could give rise to a lot of morbidity or mortality down the line. And several studies have come up with the same conclusion. Some other drugs, AZT, generally has some increase in adverse outcomes. And something I think particularly pertinent to the Zambian context, a long time ago, AZT3TC was the mainstay of antiretroviral therapy everywhere. When given in pregnancy and to exposed infants after delivery, there's an increased risk of severe mitochondrial toxicity, and potentially fatal. We didn't see that in the United States because we just used AZT and not 3TC also in the babies. This is what they were doing in France, giving Campavir to the mothers and Campavir to the babies. Tenofovir, again, a mainstay of therapy. It does decrease bone mineralization in a newborn infant. That doesn't seem to have any clinical consequences, however. Next. Poll question 3.
Okay, thank you. So the next poll question is, which of these Zambian infants is most likely to have HIV infection? So 18 months of age, mother seronegative when she presented to antenatal at 20 weeks gestation. B, 2 months of age, mother on TLE for 3 years, breastfeeding. She comes to the clinic with her husband who is also infected. For both, viral loads, according to recommended schedule, have been negative. C, 6 weeks of age, mother presented late, starting TLE at 30 weeks gestation. A viral load was non-detected at 38 weeks gestation, and infant's PCR at birth was negative. D, infant 6 weeks of age, born of mother who was rapid test indeterminate at 16 weeks, 20 weeks, and 38 weeks of gestation. Neither she nor infant received ARVs. She's healthy. So we will go to the third poll, and we are expected to start voting now. So
Okay, so actually one of the cases which we're not going to discuss but was considered for discussion was a mother who comes in late in gestation, and there's this urgency to try to get things under control, and the question came up is, what is the role of dolutegravir? The integrase inhibitors, dolutegravir included, drop the viral load very rapidly, incredibly rapidly. We're talking 1,000-fold or greater decreases within a month of starting ART. And if you've got a baby coming on the way, knowing labor and delivery is a high-risk period, it certainly sounds like an attractive option. We're going to look at this, look at the biology of this a little bit, and kind of point where actually the dolutegravir is probably the most important. So this is very old data from the United States, from even the pre-ARV era, coming into the 1, 2, and 3 drug eras here. So this is the risk of mother-to-child transmission on the y-axis, according to what mom's viral load was at term along the x-axis, and whether mom was on 3, 2, 1, or 0 drugs along the z-axis there. And yeah, thank you. So the key point is here, if you look, for example, at women who have a viral load between 3,500 and 10,000 here, which is a fairly narrow range, and you look at the risk of transmission, what you can see is there's a huge difference according to how intensive mom's antiretroviral therapy is. If she's on nothing, it's about 19%. She's on AZT alone, about 7%. 2 drugs, that'd be something like AZT and 3-TC, about 4%, and there were no cases among the women on ART. So what you see here is the risk of transmission to a degree seems to be independent of mom's viral load. Now, if we look at the babies within one treatment group, let's say, for example, we take the babies where moms are on no treatment at all. You can see the higher mom's viral load, the higher the risk of transmission. So viral load is important, but it's not the only story. The other thing that seems to be important is simply mom taking drug. Now, why might that be? When mom takes, next slide. Yeah, okay, you got it. Okay. So when mom takes antiretrovirals, the baby's taking antiretrovirals also. If we look at the ratio of the drug in the cord blood at the time of delivery versus mom's blood at the time of delivery, the nucleosides in general, that ratio is about 0.5 to 1. So almost as much drug in the baby as there is in the mom. With the non-nukes, the ratio is about 1. Efavirenz, nevirapine just go right across the placenta. For the protease inhibitors, they don't cross quite as well. Lopinavir is about 20%. But remember, lopinavir is an extremely potent drug. And 20% of mom's level is still going to be a very virologically active level. For dolutegravir, 1 study, but the ratio is about 1. And similar thing actually with raltegravir. So if mom's on ART, the baby is on pre-exposure prophylaxis. This means within a couple hours of the first dose of ART the mom takes, the baby is loaded. And we know it takes a lot less antiretroviral to prevent HIV than it is to treat it. We give PrEP with tenofovir and FTC. We know that nevirapine as a single drug prevents breast milk transmission when it's given to the infant. Okay, so we're bringing mom's viral load down, but the key thing is get the drugs into the mom. What drugs you give probably don't really make a difference. Okay, the baby's going to be loaded with drug at the time of delivery. However, after delivery, situation's completely different. Okay, the baby is going to get very little or no significant amounts of drug from the breast milk. The drug that's the biggest exception to that is nevirapine, where the ratio is only about 0.1, but basically that's enough to select for resistance if the baby is infected. The other drug where that's the case actually is 3-TC, where there's a little bit of 3-TC in the baby's blood, enough to select for resistance, and you get an M184 mutation. You also get a K65 mutation. It turns out the 3-TC monotherapy will select for K65N, which is a signature mutation that affects both tenofovir and abacavir, so that's a problem, okay? Dolutegravir, we really don't know. So the upshot of it here is when mom is taking antiretrovirals while she's breastfeeding, we're not getting any drug into the baby. We're relying on control of mom's virus in the mother's milk. Next. This is borne out in what we see clinically. If mom starts on ART by the beginning of the second trimester and she takes her medication, the chance of the baby getting infected up through labor and delivery is virtually zero. There's a very strong relationship between the milk viral load and the risk of late transmission, transmission during breastfeeding. We also know that there's a good correlation. If mom is non-detectable in the blood, she is or will soon be non-detectable in the milk. Now, what about cases of apparent failure of maternal ART to prevent breast milk transmission? Most of the cases in various studies are simply not well documented. The few that are do show evidence of lapses in adherence or detectable virus in the mom. It certainly would be nice to have more intensive look at these as to why they might be. We also notice that if you start a mom on ART, say at delivery, there doesn't seem to be the full protective effect until about a month after mom's been on ART. Again, consistent with the notion we have to pound the viral load in the milk down before we're really safe. Another situation, though, which is very analogous, about which we have more data, is sexual transmission, okay? And if the infected partner is on ART and has full viral suppression, good adherence, the chance of sexual transmission, again, is pretty darn close to zero. How does this compare with the situation with breastfeeding? Well, actually, roughly speaking, having sex once with somebody who has untreated ART is about the same risk of breastfeeding for a day from a mother who's not on ART. The bottom line, though, is that the viral load is everything. The maternal viral load is everything. So once the babies are born, we got moms on ART trying to protect the babies that way. We have to focus like a laser on mom's viral load. Full question 4.
Okay. So this is our final poll question, and it reads, for which of the following drugs are there no data on safety in children below 3 years of age? Dolutegravir, Darunavir, and Tenofovir. For which of the following drugs are there no data on safety in children below 3 years? Dolutegravir, Dolutegravir, Darunavir, and Tenofovir. So that's the poll. We can now vote. We've got 30 seconds. Half of the people in the network have not voted yet. Okay, thank you very much. So we can proceed. ART in children, Prof.
Yes. Okay. I know the question has come up about there's still a fair number of children on nevirapine in Zambia, and nevirapine sort of got a bad name, particularly in a randomized controlled trial in South Africa of giving nevirapine versus lopinavir to young infants newly diagnosed with HIV with or without a history of nevirapine PMTCT exposure. And basically the bottom line on that study was that nevirapine was less potent. This is not a surprise. We also know that it has a particularly low barrier to resistance. A single point mutation can gives basically a very high level resistance to nevirapine, whereas it takes probably 3 mutations to get a high-level resistance to lopinavir. And lopinavir is a very powerful drug. However, just about all these discussions start with however. If the child is already on nevirapine and nothing bad happened, their skin didn't fall off, okay, their liver didn't die, and children's mainly the skin toxicity, And if their adherence is good, and you're going to know that if you have a viral load that's non-detectable, you know they're taking their medication. And you have full viral suppression. If you're starting off with a 10 million viral load, nevirapine might not bring it down to non-detectable. But if you have a non-detectable viral load, you have a non-detectable viral load. And in general, if a regimen will bring the viral load to non-detectable today, it will keep it there as long as you stay on it. Nevirapine has no clear long-term side effects. It's also it didn't taste very good, but other than that, it's extremely well tolerated, okay? So under these conditions, you're already on it, it's working, it's actually an excellent drug. If you switch to Kaletra, you might get an upset stomach. You switch to efavirenz, you might have a spacey child, whatever. So it's something to consider. Now, Dolutegravir in children, okay? I am not the Dolutegravir salesman. However, I spent a lot of time selling Dolutegravir, okay? This really is the best drug we've ever had, okay? In the United States, approved by the US FDA, which helps sort of clear the path for its use elsewhere. We for quite a while now, for probably 3-4 years, we've had, in addition to the 50, we've had the 25 and 10 milligram tablets. It's approved for marketing for use in children greater than 30 kilograms. It's been studied, though, children much younger, the tablets in the 6 to 12-year-olds. There was a study using sprinkles in 2 to 6-year-old children. I think the manufacturer will probably drop that because now they're studying a dispersible tablet, which is generally easier to use in children from 4 weeks to 6 years of age, okay? So far, none of these studies have shown any problem with Dolutegravir, okay? But the closest thing to a problem is the first dose they guessed at for the very small children, for the infants, was a little low, and so they upped the dose a little bit. There's also the Odyssey study done in Uganda and Zimbabwe, which is really the basis of some recent update to your guidelines here, where they gave the 50 milligram adult tablet once a day to children weighing 25 to 30 kilograms, okay? Or the larger children too, but we're gonna focus on the 25 to 30 kilogram groups. And basically those children had levels of Dolutegravir in their blood about the same as adults taking 50 milligrams twice a day. And why are we making that comparison? It's because 50 milligrams twice a day is a labeled indication for use in adults who were previously treated with Dolutegravir. And it's known to be effective and safe and so on. Now the trough levels, because we were going every 24 hours, were actually lower in the children than the adults, but we know it's an adequate trough level. So the upshot of it here is that this is really a real good option for children down to 25 kilograms. Dolutegravir is approved for marketing in the United States for infants over 2 weeks of age. Okay, 2 to 4 weeks of age, it's approved for PMTCT. For ART, it's approved from 4 weeks on up, okay? We have powder, 25 and 100 milligram chewable tablets. You have the 100 milligram chewable tablets here, the 400 milligram adult tablets. It's important when you look at dosages, you can't give 100 milligrams to equal 1/400. It turns out that the chewables and the powder have much better bioavailability. So you can't use these interchangeably. It's a different dosage scheme for the different formulations. Drawbacks of Dolutegravir: it has a moderately low barrier to resistance, not like efavirenz does. And when you get resistance to Dolutegravir, that can compromise future Dolutegravir. But it's a really good option. It doesn't taste good. Unfortunately, we don't have a lot to do, but it's generally very well tolerated. It's an extremely safe drug. So that's all I have to say in the didactic. Can we open it for discussion or go straight to a case?
Yeah, we'll discuss 1 or 2 issues.
Yeah,
just
go
to
ahead.
get the views of
yes, happy to take questions.
Yeah, and where they were not. Or maybe probably we go through the 4 questions so that we just discuss what the answers could have been. And then we'll invite any questions to Prof or any clarifications based on the presentation. Mr. Chatonda, can we go to the poll questions? Okay, so the first poll question, or we start with the fourth poll question? Yes, the fourth. So the fourth one was, for which of the following drugs are there no data on safety in children below 3 years of age?
So I think a lot of people might want to revise their answers now that I've talked about Dolutegravir, newborn babies, and Dolutegravir also being studied in children down below 3 years of age. Tenofovir is labeled for use in the United States down to, I believe, 2 years of age. Darunavir is the exception. And something really strange came up in animal studies. And when they gave Darunavir, not at high doses, at sort of therapeutic levels, to animals that were developmentally about the first year or so of life in humans, they had a high mortality in those animals. For that reason, nobody is going to study Darunavir in children. They're not going to give it to 100 children and count how many die, okay? It's unfortunate because it works perfectly well after Kaletra failure. So, but Raltegravir, Dolutegravir, Tenofovir, great for small children.
Okay, so the answer for the fourth poll question is C. Darunavir has got no safety studies in children below the age of 3. The third one, so this is how we vote.
Okay, so this is this is not your exam, to pass your course. Okay, I wouldn't do this to you if it was. Okay, so this was kind of a trick question, and it involves a lot of weighing of which would be a little worse situation, which would be a better situation. Okay, and what I'm going to argue for here actually is option A, the infant of the mother who does not have HIV. It turns out that that a larger and larger proportion of HIV-infected babies are coming from women who come into the antenatal clinic, they get tested, and they're negative. And 4 years later, the child comes into the hospital with pneumonia and is found to be HIV infected. Okay? As your PMTCT programs get better and better and better, infections from women who are diagnosed with HIV gets really, really low. The problem is the woman who gets HIV while she's pregnant and while she is breastfeeding, particularly since right after HIV infection, there's this burst of viral replication and the risk of transmission is fairly high. To look at the other three fairly quickly, if you're stable, non-detectable viral load, as I say, you're not going to get...
Second one.
Excuse me?
Yeah, on the second one?
The second one, and question B.
All right.
Yeah, answer B.
Okay.
Answer B. Mom's been really, really, really stable, clears to have, clear social support and everything. The risk is very, very low. On the third one, C. The key here is if this baby is going to turn out to be infected, the baby was infected before mom started the TLE. As I said, once mom takes that first dose of TLE, baby's loaded. Okay, so if the PCR was negative at birth, this baby is probably going to be okay as long as mom stays on her TLE. Okay, now the repeatedly indeterminate rapid test. Rapid test is indeterminate, as you well know, could be because mom is in the window period. You repeat it 3 weeks later, and bingo, the determine's positive, bioline negative on the first test. You go back a few weeks later, and they both are positive as mom's antibody level skyrockets. However, in this case, it's repeatedly positive. We know there's a fair number of people who are perfectly healthy, have nothing to do with HIV, have a positive determinant. That's why we do the bioline to get the specificity, okay? And in someone who appears to be perfectly healthy, is repeatedly indeterminate, is probably not infected. For question 2, yeah. So the answer is, you could, I'll accept any of these answers as long as you have good reason. I was kind of voting for A, though.
Okay, so Prof will go for A, although you would accept.
I will not quibble with yes. Yes, there's reasons to be concerned about all of them.
All right, then the second one.
Second question. Why might this child who has a negative rapid test have HIV? Well, yes, somebody could mix up the rapid test samples, particularly when they're trying to do a whole bunch at the same time. Okay? A, most infants who are diagnosed rapidly, started on ART early in infancy, will have a negative rapid test at 18 months of age and for the rest of their life. They never seroconvert. This actually is true of adults who start ART right after they become infected, okay? B, the infant could be in the window period, right? Was just infected from the breast milk, 2 weeks, most are still gonna be seronegative, okay? C, baby comes in at 18 months, poor growth, delayed development, severe pneumonia, looks like AIDS, but has a negative rapid test. That's seronegative HIV infection. We see this in children who are severely infected. They serorevert. They either never seroconvert if they're a small baby, or I have seen, I saw a child 14 years of age who was infected probably at about 10 years of age, no antibodies to HIV, no antibodies to anything, no CD4 cells, severe AIDS, okay? So immune suppressed, they don't have a response to the virus. When does a rapid test, question 1, when does a rapid test become negative in most infants? By 9 months of age, it's negative. By negative, I mean determined negative, bioline negative. By 9 months of age, most exposed infants should have a negative test. By 12 months, very few of them have a positive determined, and essentially all of them will have a negative bioline by that point. So if you get a fully positive rapid test, in a 9-month-old, it's a little suspicious. If you see it in a 12-month-old, it's very suspicious. And by 15 months of age, you are really almost certain that the baby has HIV. And the key here is that the bioline is positive. It's intentionally not a sensitive test, okay? So yes, you're gonna send a PCR on that child, okay? But you need to be thinking about other measures.
So thank you very much. And I think the first question there was, the answer was B, if I'm not mistaken.
Yeah.
Which is 9 months.
Yeah, I know, actually quite a few got that, yeah.
All right. So thank you very much. We'll now invite anyone from the network to actually ask any questions with regarding to the presentation by Professor Watson. We'll allow just a few so that we can go in the practical cases so that we can have more discussions concerning issues of maternal and childhood HIV. So I think there's something that has come from, I'm not sure who, but CC, saying recently the Zambian guidelines are the policy brief to avoid NVP-based regimes in preference to efavirenz. What is your comment based on cross-resistance, TB co-infection is a good indication?
Well, I guess to start with the TB co-infection, rifampicin lowers nevirapine levels more than it lowers efavirenz levels. How clinically significant that is quite frankly not clear, and there are discrepant data on that. In general, efavirenz is probably a more potent medication, and again, I was talking not about starting children on nevirapine. I was talking about the child who's already doing well on nevirapine. And the question is, do you mess with success? And the other issue is we're looking at the dolutegravir option coming up for children. This is on the horizon. This is coming to Zambia. Do we make a switch from nevirapine to efavirenz, possibly deal with the side effects of efavirenz, and then, 6 months later, a year later, make another switch to dolutegravir? It's really kind of a practical issue that you have to look at. In addition to things like, maintaining nevirapine in the pharmacy, as fewer and fewer people take it, becomes more and more difficult, and so on.
Thank you very much. And Chilenge, I think, is trying to find out which one is more specific between BioLine and Unigod for HIV confirmation.
Between BioLine and Unigold, I don't know of any direct comparisons. They are in the same sort of group, and that the determinant is highly sensitive, but not as specific. So you get more false positives with the determined. That's why you get these indeterminate results. Determined positive and the second test negative. BioLine, there's actually been a number of second tests. They're all characterized by lower sensitivity. So that's really only the people with, higher levels of HIV antibodies that show up positive in the second test.
Why are we just sending questions? We can't see questions being asked directly. Are we having technical challenges? So we are seeing more people sending in questions than they are asking.
PCR at birth. Can you talk a bit more about PCR at birth? That question is from Skill.
I'm sorry, talk more about what?
PCR at birth.
The PCR at birth. There's a resource issue here. I think we're moving into a situation where if the babies are going to be infected, once we know about a case, okay, and we can work with the patient, we have very, very powerful drugs. If we can get them in the patient, things should be okay if the baby's not infected up to that point. If we get ART in the mom, get the PMTCT drugs into the baby, where we have a lot of concern is babies infected before moms start on ART, particularly late presenting women. HIV can be transmitted starting sometime in the second trimester. And if women are not presenting to 20 weeks, 30 weeks, 36 weeks, in a lot of those cases, that baby is already infected. There's nothing that we can do to stop it. What we need to do is diagnose it and start treatment as fast as possible. So I think that for those reasons, as time goes on, the birth PCR becomes more and more important. That's the one that's going to show up. And at the other end, the problem that we run into in Zambia and all over Africa is basically adherence to care falling over time. Not getting all those 6-week PCRs and fewer of the 6 months, and moms sort of drifting out of care is the other issue. So I worry sort of most about then, what's happening at 9, 12, 18 months when mom has drifted out of care but still breastfeeding.
Okay, so thank you very much. We will now ask Chilenge to share their case. Chimunya, are you ready there to share your case? I know that a number of questions have come through the chat. We will try to address them as we discuss some of
failed, but we don't know what was happening to the viral load and to the adherence and so on. So we don't know as much as we'd like. It does appear that non-detectable plasma viral load equals a non-detectable milk viral load equals full protection. So I think, I know we often use like 1,000 in this setting as treatment failure, but if you're sitting on a viral load of 1,000 while you're on ART, eventually it's going to completely fail. It's going to fail slowly depending on what drug you're on. So I think in general, yes, we should be looking for non-detectable, particularly during the breastfeeding period.
Okay, so thank you very much. I think Chimunya and team are ready to present. Chimunya, over to you from Chilenje.
Yes, Doc, we're ready. Good afternoon. Good afternoon, everyone.
Would you kindly raise your voice or move close to the microphone?
Okay, good afternoon, Doc.
We can hear you. We can hear you, but with much difficulty. Can you move closer to the microphone?
Hello, now, am I clear?
Yes,
Hello?
perfect. Perfect, okay. Yes.
Okay, good afternoon, everyone. I'm going to present a case from Baoleni Clinic. This is for an 8-year-old boy, DK, 8 years old, with HIV on ART for 5 years now. This boy was living with a grandmother in Mumbwa district, was recently transferred to Baoleni Clinic. That was 2 years ago. And he's currently doing well at school. He's in grade 3 and under the care of the closure was done by the grandmother 2 years ago. He has 2 siblings. That's one who's 10 years old and the other one is 14 years old. Both his siblings are HIV negative. The mother's status is unknown, as the mother is somehow resistant to testing. Sorry about that. So the medical history is that the boy has no history of any opportunistic infections. Was first diagnosed of HIV in 2015. That's April 2015. He has some history of persistent upper respiratory tract infection. That is in April 2018, and conjunctivitis. He's been on ART from 2015. That was the 23rd of April 2015. That's when he was initiated on ART. The first regimen of ART that he's been on is not well known because the auntie was not so sure. But from the time he came to Baoleni, he was changed to ABC, 3TC, and Nevirapine. On physical examination, the temperature was 37, weight 25, height 125 centimeters, BMI of 15.1, and there were no other any abnormalities seen. It was classified to grade stage 1. These were the results that were available. ALT 23 units per liter, AST 24, creatinine 52.6 micromoles per liter, CD4 was 603 cells per mil, and then CD4% 25.5%, viral load 19 copies per mil. These were results for 27th October 2016. And then viral load was done again in September 2018, and it's at 59 copies per mil. So our question now is, I'm not sure they're able to see it, but it's, can this patient be transitioned to a non-Nevirapine regimen? Thank you.
Thank you very much, Chimunya, for that case. So this is an 8-year-old boy who has been on ART for the past 5 years. I think came from one of the districts in Eastern Province, was transferred to Lusaka under the care of his aunt, is now said to be doing fine and going to school. He's got two siblings who are HIV negative, older than him, of course. And then the mother did not disclose the status, but we know that the child is infected and on ART. He's currently doing fine in that he's virally suppressed as of the latest viral load. And initially was started on some ART regimen that we don't know, but currently is on ABC, 3TC, and NVP. And the question is, can we remove this child from NVP? So we will now open it up for the people in the network to make their contribution with regarding to this case. Any thoughts? Minga Mission, are we there? We can't see you. St. Francis? St. Francis, any thoughts on this case?
Looking at what Professor was sharing, I think we can maintain the regime.
You are not.
Hello, St. Francis?
Hello.
We can hear you. Yes.
I'm saying from the area discussion that we had, and I think some of the data that was shared, I personally feel we should maintain the regime since the child is doing fine, meaning he's seeing that his virally suppressed. I think we should just maintain on the same ABC, 3TC, and verifying.
Okay, so first try to get a lot of views from Eastern Province. Remember, this child actually came from there, and probably before reaching Lusaka could have had visiting other hospitals. Chipata, what's your thoughts with regards to the NVP in this child who is virally suppressed and doing well? Chipata, any thoughts?
Yes, Dr. Mupeta, I think this is the right time to change the child from NVP to a evidence-based regimen, based on the fact that the client is still responding on NVP, the child will still respond on NVP. It's the right time to change the client.
Okay, thank you very much. Chimunya, I will ask you that you stop sharing. Would you stop sharing your slides? And Katete, would you mute? Thank you very much, Chimunya. So any other contributions? I think Njase Aban also wants to contribute. Yes, Njase, you are on. You can make your contributions. Njase?
Good afternoon.
Good afternoon, sir.
Yes, thanks so much. I have 3 questions which I want to be clarified by the presenter. Hello?
Yes, we can get you.
Yeah, the first question is the HIV status of the father. Since the mother is not disclosing the status and the 2 siblings are negative, did they try to find out the HIV status of the father? Then the second question is if there was any history of STI in this boy. Because if there is history of STI in this boy, then we'll rule out the issue of mother-to-child transmission of HIV, especially that the 2 elder siblings are HIV negative. Then maybe the boy could have gotten the disease where he was being kept. Then the last question is the weight of the child, because I feel since now we are on transitioning patients to POD, and if this baby has this child is beyond the recommendable age weight for POD, then we can maybe think of switching the child to TOD.
So thank you very much. the father actually died some 5 years ago, almost at the same time the child was starting on ART. Dr. Thomas, any thoughts on the STIs being present as the reason why this child got infected? Is 8 years old.
I think the mother would have seroconverted later on, even though the first two siblings are negative. Because the child is 8 years now. Is there any other thing suggesting STI? We didn't get anything like that.
Okay, I don't know if we are clear with that, but any thoughts on the other questions? And I think about the transition, Dr. Mwangela. Yes, Njase, before we give another person. Njase?
Yes, maybe just to clarify on the STIs. I think that's where most we miss it, because sometimes children are being abused. And in the instance where the child is abused, especially where the child is separated from the siblings, they may get the disease from the people who are abusing the child, but really not mother-to-child transmission. That's why I brought in the issue of STIs, because I was thinking maybe where the child was staying was being abused by somebody who is HIV positive. Thank you.
Thank you very much. Dr. Mwangela.
Yeah. Thanks very much. I don't know if you can get me. Can you get me?
Yes, we can. Yes, we can. Yes.
Yeah. Just to comment on the STIs, I'm not sure why there is a thinking that the child may have got infected horizontally. It is possible, but at the same time, it's not uncommon to find a family where some children are negative and then you get a positive child. So it doesn't necessarily mean that if the others are negative, then this particular child could have been infected by sexual abuse. So it is possible to still be, most likely still mother-child transmission, especially that the child presented and started treatment at 5 years. My other comment is on the changing of nevirapine. I think ideally, if someone is doing well, you don't want to change the treatment because this child is suppressed. But I think we all know the guidance from the Ministry of Health that we should be transitioning our patients from the use of nevirapine to, for the younger ones, to a PI-based regimens, and for the older ones to efavirenz or dolutegravir. Sorry, I missed the weight of this child, but if they're over 20 kg, you could even change the nevirapine to DTG. Otherwise, you could also change to efavirenz since the child is doing well on nevirapine.
Yeah, so the child is 24 kilos.
Yes, so there's no harm. You could actually change the child to dolutegravir as an option.
Okay. Dr. Mary Boyd, you had some thoughts on that?
Well, not much to add. I think generally, though, the DTG we would switch when the child is 25 kilos. But the only other point is that, yes, there is a request or a requirement for all the PEPFAR-supported countries worldwide to switch from suboptimal regimens. And this MVP is one that is considered that way for the reasons that Doug explained, although, of course, there's some caveats in that explanation. So the fact is that within the next few months, there will be no more MVP in Zambia. So it is a movement that we all have to embrace and carry out. And so I think it's good to start, talking about these kids and talking about what are the options in this environment. And I think, as has been said, probably efavirenz is what I would pick for this child over lopinavir, although the lopinavir shouldn't be a big issue for this child because they can take a tablet, right? So
thank you very much. I think Dr. Mlenga has something to say regards the case. Dr. Mlenga.
Hi, Dr. Mpeta. Prof. Watson, how are you?
I'm well, and you?
Fine, thank you. I just want to, add to the words which have been echoed by Dr. Boyd, Professor Watson, and everyone over the NVP. Apparently, we are not going to and the only NVP which is going to be available for now is only for prophylaxis. And again, even that is also in the way where we're trying to bring in the Dolutegravir granules, and also we're trying to bring in also the Dolutegravir as well for those under 2 weeks where you're going to give the Dolutegravir. So we need to emphasize that NVP is on the way out. And this discussion, I think, has come at the right time on which drugs we need to be using in such a population. Thank you.
Thank you very much, Dr. Mlinga. So I think we have tried to get to a number of views on this child. We understand that this child is doing well on nevirapine, and I think the earlier discussion was that if somebody is doing well, you do not switch. But however, because we are not going to have any more stocks of nevirapine, we are all urged to switch. Now, this child is just 1 kilo short of, being qualified for DTG. And this goes to Dr. Mary Boyd. Can we put this child on an accelerated feeding program to meet the 25 kilos? Or can we switch to a PI pending for this child to get, the appropriate weights to start DTG? Dr. Boyd.
I would lean towards waiting for the child to reach 25 kilos, and in the meantime use the PI. Yeah,
so no need to really force this, feed this child
every day.
Of course. So
Dr. Peter, sorry.
Yes.
I think I need to be guided by the pediatricians. There's data which has come out that we need to lower to 20 kg for DTG 50 milligrams. I think the comments from the pediatricians.
Dr. Mulanga, I think that's what we are told. From 20 kg onwards, we can use DTG.
The 50 milligrams, and Unitaid is working with other pharmaceuticals to have that formulation. Chai is also working on those. So I think, and even WHO is also working on release of 50 kg for 20 kgs.
50 milligrams.
Yes, that's what we are told.
Yes. Any thoughts on the formulations in terms of for the...
Well, yeah, as far as giving the 50s to children below 25 kilograms, I was just quoting you the data that exists, and this is a study done in Africa where they looked at 25 to 30 kilogram kids. This is what we can say. I think it's going to be really hard to kill anybody with Dolutegravir, though. Okay, and it's an absolutely wonderful drug. Almost everybody on the planet with HIV should be on Dolutegravir. I understand that the smaller tablets are supposed to be in the works for Zambia, and 25 milligram tablet would be about the right size for 25. It's about 1 milligram per kilogram, but when you get to the smaller children, really small children, the dose goes up to about 1.5 to about 2.5 milligrams per kilogram for the infants. But I think we may be looking towards transitioning people to Dolutegravir. So we need to fatten them up now, or whether we can just go ahead and switch them now. I don't think it's a big issue.
So just to get it clear, for those above 20 kgs children, like in this case, is it a 50 milligrams or 25 milligrams, as you say?
Well,
which one?
Depends on what you have. If you don't have the 25 milligrams. All I was saying is I've not seen data on children below 25 kilograms taking the 50 milligram tablet.
Okay.
Certainly there's been plenty of study with the 25 milligram tablet, the 10 milligram tablet, and so on. In that age range, in the 8-year-olds, yes, we have data and we know exactly how much to give them to get a certain level. But as opposed to tenofovir, you never want to overdose somebody with tenofovir disoproxil, okay? Because you're going to get kidney and bone problems. And I've seen it many times in children. Dolutegravir is in a completely different category in that it's safe and we're not worried about overdosing.
Okay. So Dr. Mlenga, any thoughts on when we are likely going to have other dose formulations for Dolutegravir, especially for children And sorry, Dr. Mlenga, before you come in, would ask the last case coming from Lewanika if they could start sharing their slide as Dr. Mlenga is making a comment.
Yeah, so we met the pharmaceuticals, the generics, last month under United and also Child. And we were assured that the 20 milligrams should be available come end of the year. Then also the formulation of DTG with ABC and 3TC should be available by March next year as well. I think those are that's the information which the industry gave us.
Okay. Thank you very much. So this is now another case. I think I will just try to amplify what we've been discussing. May I request that those whose mics are on, please kindly mute them. So Lukonga and team, are you ready to present from Lewanika?
Yes, we are ready.
Yes, please go ahead. You have the floor.
Good afternoon, everyone. This is a case coming from Lewanika, presenting under Mongu Urban. So this is a 13-year-old male diagnosed with HIV 9 years ago at the age of 5, started ART 4 months after diagnosis. He is currently in and out of the hospital due to ill health, admitted 2 months ago for persistent cough, persistent diarrhea for above 1 month, loss of appetite, weight loss, oral candidiasis, which responded well to fluconazole. Stays with a grandmother who reports good adherence. But when the child visits the mother, there's kind of poor adherence. History of TB, which was diagnosed by chest X-ray. That was two years ago and was treated. The child completed TB treatment in February. Repeat gene expert the repeat gene expert 2 months ago was negative. Drug history, 29 May 2010 to 28 May 2013, the child was on ABC 3TC equivalence. Then he was switched to AZT 3TC nevirapine. That was in 2015. The reason for the switch was not known. Then 2016 to 2018, they did another switch. That was ABC 3TC equivalence. They suspected treatment failure. Then from 17 December 2018 till now, the child is on ABC 3TC lopinavir. Fecal exam, temperature was 36 degrees, BP not done. The pulse was 55 beats per minute, respiration 20. Then the weight was 19 kg, height 132. The MOH SD showed severe malnutrition. The child, on examination, the child was wasted, had brittle hair, and showed no interest to the surrounding, but had no edema. Rest of the exam was unremarkable. Available results, 2010 only did the HB, which was 10 grams per deciliter. 2013 CD4 was 168. 2015, the CD4 was 598. The 2016 CD4 was 296. 2017, it dropped to 30, and viral load was done, which was 52,949. Then the HP was 10.6 grams per deciliter. 2018, CD4 was 1. Then the viral load went to 242,275. Then HB was 9.4. 2018, the viral load was done. That was 42,699. So for the 2018, there are 2 viral loads, and they only did it in space of 2 months. So our question is there a need of a genotype? What second-line regime would be best for this child?
Okay, thank you very much. You can stop sharing. So this is a child who is not doing well on ART. Is 13 years old. Is actually spent much of the time last year in hospital. He was treated for TB. The CD4 is falling in his ART regimens, and the latest being ABC3TC and the PI. And if we see the reason is that in 2018, was changed due to treatment failure, and they actually failed to use AZT because the child's HB was quite low. Any thoughts? I'll allow 2 from the spokes, and then we'll wrap it up from here in the hub, and then we try to see how to summarize the case. So any contributions from the network? Any hand? Okay, definitely we'll just have to volunteer people here then. Livingston, I know that you are dealing with a complicated case like this one, so we have picked on you. What are your thoughts and what are you doing to such children? Livingston Central. I know in Livingston there are several facilities. From the hub? ID physicians, pediatricians.
To be honest, it's a little hard to follow regimen this person is on and the viral load. So, because the viral load said 2018, but the regimen was also, the regimen is 2018. At which point was this viral load taken? Was it before the switch to lopinavir or after?
At the switch.
At the switch. At the time of the switch. So we don't have a viral load since the switch, right?
Yes, yes. Okay. So there are 2 viral loads. There's the first one was in February, and then in a space of 2 months, in April, which is 2018, another one was done. And that was the one which informed the last switch.
Got it.
Yes. So if you see the last switch is just a PI, replacement of efferents, and the reason was because the HP was low, so they felt uncomfortable to give AZT. So the question they have, should they do a genotype on these patients? And why? Being told Livingston hasn't joined. Chipata Central, we are starting with the big hospitals. You see these patients. Dr. Mwinga.
Thank you, Francis. Going through the case, I think there are a lot of issues that beg to be explained to us vis-a-vis the rationale that was being used when changing the regimen from an AZT-based to ABC. And then when they noticed that it was failing, the ABC 3TCFV, they in essence just removed the EFV and added Aluvia. So in essence, we added a single drug to a failing regimen. So I want to know around what premise they were changing the it would be the best thing to do. So I think the child is not naive to these ones. So we may need to do that and see what best regimen we can actually come up for this child. I think that will be what I'll contribute.
We had lost you for for a few seconds, but I think you are saying that the genotype would be the best way to go, is it?
Yes, and then I was also asking on the rationale for the changing of the regimens, because when you look at the last one, it was just alluvia that was added to a presumably failing regimen. So I'm asking the rationale that was being used when changing these.
So the reason why they did the single switch is that they failed to use AZT because the child's hemoglobin was 9.4, and they thought the issues of anemia, so they opted to maintain ABC and 3TC and then just change lopinavir.
Okay.
Dr. Mwenga.
Yes, I've gotten that point, but in any case, I think we may need to explain further on that, because the anemia precedes or preceded the use of the AZT. If the anemia was treated, I'm sure AZT could have still been used in this patient.
We are kindly reminding those from Sons of Thunder to kindly mute your microphone. We are getting a lot of feedback. Or you're trying to ask a question. All right, then go ahead.
On the genotype, we've been doing this since 2005, and we were getting a lot of people on the triplet with high viral loads. So we've been going back on them and doing the SD biolines. And we've already found 4 that are actually HIV-2 or HIV-1 and 2. And we have switched their regimen to the lopinavir, and we're waiting to see what their new viral loads are going to be.
Okay, thank you very much. So I think that was some innovation from Sons of Thunder there, where they had to actually check for HIV-2, especially that this was just recently introduced, and they found that a number of children, 4 I think, had co-infection of HIV-1 and 2. Dr. Achambo, any thoughts on this child?
Hi, I was actually just going to respond the same way that Dr. Mwenga responded, that genotype would be helpful. I'm not sure I followed all the regimens and viral loads correctly, but most likely this child is failing treatment based on the clinical symptoms that the child has now, and looking at the history of the different regimens that they've had. So a genotype would be helpful. One of the bigger questions is, looking at this history, what treatment options do we have? So they most likely have maybe L74V from the abacavir, they may have TAMs from the AZT, and the NNRTIs are not going to work. So one of the questions I have is, when did the child stop TB treatment? When did the child complete ATT?
Last year in February 2018.
Oh, okay. All right, so I think we'd still need to look for TB at this time, because with these symptoms that the child has, I thought it was February this year, so we still need to look for TB. It could be the cause of the anemia, or it could just be treatment failure from being on an ineffective regimen. So I think a genotype would be helpful, and looking for OIs like tuberculosis.
Okay, thank you very much. Any contributions from the hub? St. Francis, you are back now. Yes, you can go ahead.
So for me, I wanted to comment on adherence as well. In as much as we are looking at the different drugs that the child has been on, it's very important. I saw that whenever the child visits the mother, doesn't take the drug correctly or something like that. So in as much as we are even changing or switching these drugs, we need to make sure that adherence issues are also addressed. Otherwise, we might do a genotype and we get the results of which drugs are appropriate, but as long as adherence issues are not fully addressed, this child might keep failing. Thank you.
the facilities?
I think the change from ABC 3TC efavirenz to ABC 3TC lopinavir with an HB of 9.4, I think 9.4 is not too bad. And this child is wasted, maybe nutritional factors are there. Depending upon the MCV and other parameters, we could have corrected that. Maybe we could have changed the proper second-line regime with the AZT3TC and lopinavir in this case. That's one thing I think. And now, of course, since the child was exposed to so many drugs, the resistance is needed now. And again, the CD4 is only one. Do we wait for the resistance result for how many months? I don't know. Or we go to an empirical tail-line drug? That's a question to be discussed. I think Professor Watson can take it up from there.
Prof, you've been put on the spotlight.
Well, I was, my impression of this child starts with he's near death. So we need to act quickly, and I think we need to look at several possibilities. Whether there's tuberculosis, as someone mentioned, and a gene expert, if it's positive, it helps you, but if it's negative, there's lots of false negatives. So I think a more thorough investigation to look for the possibility of tuberculosis. The adherence issue, again, is a major issue. The child recently started on lopinavir, and as pointed out, there may well be a lot of nucleoside resistance, but just a lopinavir by itself with some partially effective nucleosides should make quite a difference, and clinically we're not seeing that. So perhaps the child is simply not taking his new medication, and we need to get to the bottom of that. The other is the medication he was put on was lopinavir, and he has diarrhea. Does he have diarrhea because of the lopinavir, or in spite of the lopinavir? Is he even taking the lopinavir? We may be making, this child who is extremely ill, it's possible that the GI side effects of lopinavir are making the situation worse. Now, no, I'm not the Dolutegravir salesman, but sounds like a great option here, okay? Particularly because it doesn't cause diarrhea. It's extremely potent. And even if we don't have good nucleosides, and it might take us time to sort out which are the best nucleosides, he would still be doing a whole lot better. The diarrhea also, in this child's situation, you could have cryptosporidiosis, for which, bottom line is, the best treatment for cryptosporidiosis is ART. And we're going to have to get it under control and hopefully keep them alive. And in my experience, it's generally taken a few weeks before the diarrhea really settles down with some immune reconstitution. So it's going to be close here, put it that way. Generally, if you've got a lot of TAMs and so on, tenofovir is a drug that sort of keeps on going the best, although none of them are great. You would have to watch this child's condition pretty carefully. I'd be, again, careful about a drug that has a narrower therapeutic margin, what's his renal function and so on, and could you dose him accurately? So I'm not too sure. The point I think that was Dr. Thomas made, 9.5 hemoglobin's not that bad. And getting the virus under control, no matter what you do, will get his hemoglobin up.
Okay, so thank you very much. Lukonga, and I think there are so many issues on this patient, like everyone else has pointed out. There's the diarrhea, the possibility of TB being there, malnutrition, I think, and this child is actually 13, which is underweight, immunosuppression and adherence issues. So we have to see how we can take care of the things that we can, and then we try to see and follow up with the recommendations. Has it been made any clearer for you, or do you still have any questions? Lukonga, I'll start with you before I go to Chimunya and team over their case.
Okay, I think it's clear. We'll just wait for the recommendations that have been mentioned.
So now this child is near death, as we've been told. The CD4 is 1. This child was recently admitted, malnourished. Any follow-ups in that regard on this child?
The child came back for farmer's follow-up 2 weeks ago, and his speaking at least is stable.
How is the weight? Has it improved? Because, you know, there is the aspect of trying to change to Dolutegravir. How is the weight?
The weight is 19.5.
Okay, still quite low. Yes, Dr. Foloshi, any?
Sorry, I was just saying that what recommendations are we making for the ART for both babies? I've heard the suggestions, but what clearly should they go with? Are we going to use the Dolutegravir with AZT3TC?
Let's start with the patient with a lot of issues. What ART can we have from the pediatrician and infectious disease? Yes.
Just a clarification. How is the diarrhea now when the child came for review?
Lukonga, how is the diarrhea? Is the child still having diarrhea?
No, the child only has at least once in a day compared to like 2 months ago.
So it's still there?
It's still
At
there.
least it has reduced. All right.
It has reduced.
Thank you. Dr. Boyd?
Bleach is working.
I mean, it sounded like it was very important to get an update on which direction this patient was going. It sounds like it's not worse, but it's still really bad, in which case maybe AZT3TC and Dolutegravir. Although I think it's important to clarify, because honestly, I think that we might be confusing the network a bit, because we said Dolutegravir for 25 kilos and above, but it sounds like there's new evidence to suggest that we can use it for 20 kilos and above. And I mean, if you're going to use it in any kid who needs it, this would be the kid. So.
Okay, thank you very much. Any thoughts on the first case? And I think we did discuss that NVP is being phased out. So despite this child doing very well, we have decided that the child has to be switched. Now, what regimen, Dr. Foloshi?
Sorry, because I really thought the child still had diarrhea, but with that clarification, maybe we should be considering something like a PI, Dolutegravir, because we don't know how long the child was on the AZT, or AZT3TC with Dolutegravir, or AZT3TC with the PI. I don't know. The weight of 19 kg. I don't know how the child who's 13 years old is 19 kg and is stable. That's very, very thin.
Yeah, it's still quite malnourished. And I think, Lukonga, one of the issues we should follow up immediately is to ensure that this child is on some, feeding program for the treatment of malnutrition. It's quite malnourished, this child.
Just a clarification. Do they have standalone DTG there? Otherwise, maybe AZT, 3TC, and Aduvia can continue. Maybe do a viral load after 1 month.
And even if they had DTG, do they have the 25, or which is very unlikely, and the 50s would not be advisable, I think, for this week. So
I think with the current situation, AZT, 3TC, Aduvia, do a viral load after 1 month, since the diarrhea has come down to at least once a day.
I don't think he's had a viral load on the Alluvia yet.
Not yet.
Yeah, so, maybe virologically we're doing okay. And you'll get that back faster than you'll get a genotype.
So we should think of doing an immediate viral load. And then on the first case, which is phasing out of nevirapine, which is a recommendation from, or a guidance from Ministry of Health, as we are phasing out nevirapine. From the hub, I think Dr. Foloshi posed this question. Mary, Dr. Nyaku.
Repeat the question, sir.
The phasing out, the first case, what clear recommendation are they going out with?
think we said ABC, 3TC, and Lopinavir. Is that correct?
The child is 8 years, eh?
It's 8 years suppressed and 24 kilos, just 1 kg shy of what is recommended for Dolutegravir.
I think we can continue with ABC, 3TC, efavirenz for the time being, I think.
I think that would still be fine because maybe it would get a bit confusing for the child. Because eventually this is a child who will end up on something like once a day, like TLE or TLD. So I think to prepare for that.
That is another thing. DTG can be used from 20 kg and above, but TDF, the minimum weight is 30 kg. So they shouldn't have that impression the child can go into TLD soon, no. Yeah.
All right, so thank you very much. We'll, however, ask, and Chimunya, I think, did not comment if at all they were satisfied with what has been given out so far. Chimunya?
Yes, Doc. Maybe I missed it. Are we saying we're going to switch this? We have about 10 of them, and we've already put.
Sorry, we can't get you clearly.
Hello? Am I clear
Yes.
now, Doc?
Yes, you are.
I think I missed the complete regimen that has been advised because we have about 10 kids that we need to switch. So maybe it can be mentioned again so that I pick it well.
So we are saying this child is doing very well, and what we have recommended so far is Becavir, lamivudine, and efavirenz.
Oh, okay.
Yes, because we have to phase out with the NVP. All right, I think it has been quite a roller coaster. We had quite a number of issues. And I should say that we did receive an overwhelming number of cases for this for today's presentation. However, because of time, we could not take all the cases submitted on board. So it has been quite an interesting discussion. Thank you very much, Professor Watson, for joining us in the hub and all the way from the US, and everyone who contributed today. Now, before we go, I think the usual reminders of us sending the attendance list, and then GNC is also going to give the CPD points, and I think it has now been decided that it will be 2 points per ECHO attendance, and we hope that you'll be contributing, not just being passengers. So from myself and everyone in the hub, it's next week, and the topic for next week?
Hepatitis B.
It will be hepatitis B and HIV co-infection. So please make a date, and we meet next week at 2:30. Thank you very much.